Good evening and welcome. This is the first of what we hope will be many live webinars. At Friends for Mental Health, our mission is to offer support to relatives and friends who have a loved one with a mental illness. I am Beverly Hank, and I am very pleased to introduce our very special guest for this evening. Dr. Serge Beaulieu is one of the very admirable psychiatrists and directors associated for many years now with the Douglas Institute. He is also associate professor in psychiatry at McGill. His popularity stems from the fact that he is an outstanding specialist in bipolar disorder, which for families can be a puzzling illness. Caring for someone with bipolar disorder can place heavy burdens on the family, particularly if they are not equipped with the knowledge and skills needed to cope with mental illness. Tonight, Dr. Beaulieu will help us to understand the complexities that accompany bipolar disorder and provide guidance in terms of both diagnosis and treatment. Please note that we will only take questions after Dr. Beaulieu has finished his presentation. Would you please wait to make sure that you have the microphone before asking any of your questions? Otherwise, it won't be heard online, so we'd ask you to do that. And would you also please be sure that you've turned your cell phones off? Please help me welcome Dr. Beaulieu.
Well, thank you very much. This is a great occasion to explain and maybe demystify a little bit the bipolar disorders. And I insist on the S. I was saying earlier that we could spend all night talking about the little S there at the end of bipolar disorder. That's a very important concept because it will affect not only the diagnosis, not only the detection of the problem, but also its treatment at the end. So I think that we were talking a few minutes ago about the percentage, the prevalence of the bipolar disorder. Some will have read that maybe it's 1% in the population. Some others will say, oh, it can go up to 8%. It all depends on how you define bipolar disorder. So we'll try to get into the nuances, complexities of the bipolar disorder and why does it create so much, sometimes confusion, to say the truth, about the diagnosis of bipolar disorder and misconceptions as well. So without further delay, let's go into the crux of it. Bipolar disorder type 1. This is the classical bipolar disorder that you've read about. Classical manic phases where the person is brought to the emergency room by family members and so on. Don't need to be a psychiatrist to diagnose that there is something wrong. And it's usually a manic phase, can be accompanied by psychotic symptoms or not. And clearly this is something that responds well to lithium usually, or Epival, or Aldol, or antipsychotics. And usually patients get better within 3 to 4 weeks, and they go back with their life, or if they're not lucky, they will get into a depressive phase following the manic phase. Bipolar 2 is the same issue as the manic symptoms, except that the symptoms are less pronounced. And we'll go into the details of what are the symptoms of hypomania and mania. They have depressions as well, but they don't have the full-blown manias. They have what we call hypomanias. And again, we'll get into these details in a few seconds. If you add that bipolar disorder to the bipolar 1, then the percentage, the prevalence goes up to 3% of the population, according to some studies. Then comes the very fuzzy, grayish zone of the bipolar spectrum, where psychiatrists disagree sometimes, where you will have a psychiatrist who will say, no, this is bipolar disorder, and someone else will say, no, this is depression, no, this is attention deficit disorder, no, this is a personality disorder, and that becomes a little bit messy. Okay, so The bipolar spectrum is more complex to define. We'll try to go into some of those details later on. And then you can have authors who will say, well, it's more than 4% of the population. Some authors like Julius Angst in Zurich has studied that for all his career. He is now over 80 years old, and he would say it can go up to 8% of the population. So it all depends on how you define these things. More and more in psychiatry, as well as in medicine, we try to shy away from categorical definitions of disorders. We try to go more towards spectrums, because biology is complex, and it's a bit, too overly simplistic to imagine that we can say, well, this is a bipolar disorder, that type, and things don't move around and things don't change over time. So it's too simplistic to use categorical classifications like that. So we all hope, as psychiatrists, physicians, that in 20 years from now, we will be able to do some blood tests and be able to diagnose certain genes that your person may have, and that will help us to predict what kind of illness will develop over the years, and therefore better choose a better treatment for that patient. Bipolar disorders are very democratic. They don't make a difference between gender. It touches both men and women at the same percentage. The cause is, as far as we are understanding these disorders, they are genetic, but they are highly influenced by the environment. The stressors in the life of the person, the events, the catastrophes that might happen, societal, cultural effects are certainly important. As you may understand, we'll talk a little bit about that. The field of epigenetic is evolving over the last 15 years, and we now know very much so that the environment can influence the development, the triggering, the evolution, the worsening, or the improvement of a disorder. The peak age of onset is unfortunately adolescence. And I say unfortunately because this makes the diagnosis extremely difficult to make. Try to imagine diagnosing a teenager with a bipolar disorder. Of course, a teenager wants to party. Of course, a teenager will spend nights without sleep. Of course, they will try using drugs here and there. And of course, they may have behaviors that will surprise you and will trigger doubts in your mind that that young person has maybe a bipolar disorder. So it's very confusing sometimes, and that's why physicians are very, very, very careful not to overdiagnose these things, especially in a young person. And I say teenagers, but you can extend the bracket to even 25 years old and so on. So the consequence of that is that all the studies over the last now 20 years have confirmed over and over again that there is a big 10-year gap between the first onset of symptoms and the moment the person will have a diagnosis of bipolar disorder. That period of 10 years is long enough to create a lot of damage, possibly. Okay, so that's unfortunate. That's something that we are all trying to improve by having better methods of detection, certainly seeing patients much earlier than we would do before, and having a high level, a high degree of suspicion, and keeping an eye on the evolution, not letting the young person go, well, you can go home now and no follow-up and things like that. We don't do these things. We try to follow them. Secondly, I have, as all psychiatrists do, when we have an adult patient telling us, well, I have my kids and I have one of my kids who worries me a little bit, I think that maybe something, we pay attention to that. We try to offer a service as well for that, so that we can detect a problem in the population at risk. Okay, so that's something that's quite current in the world at this point in time. So how does it present? Well, let's try to get a little bit into the symptoms here. So I was talking a little bit about mania, psychotic mania, or pure mania without psychotic symptoms. By the way, psychosis means not in contact with reality. Could be hearing voices, could be having paranoid thoughts, or imagining things that are not real. And these phases are called mania. That person who presents these kind of symptoms can no longer function, can no longer work, can be a danger to herself or others, and therefore needs to be hospitalized. By definition, any hospitalization then is called a manic phase in these situations. Of course, we can hospitalize for depression as well, but when they are the type of agitation, manic symptoms, we call this a manic phase by definition. Then there are also the depressive phases, which can happen, and the sometimes more complex situations where you have a manic phase or a depressive phase with mixed elements. And what we mean by that, that could be someone who has all the agitation and the excitement of what we see in a manic state, but the content of the thoughts are not grandiose. These are not projects. These are not euphoric ideas and so on, or feelings, but these are what we call dysphoric sensations. So sadness, anxiety, suicidal thoughts. And the person has the agitation, the energy, unfortunately, that makes them more agitated. So you can imagine the combination of someone who has intense suicidal thoughts, but is not stuck in bed depressed, but in fact is agitated with racing thoughts in her mind. That person is at high risk for suicide because they have the energy to act. Okay, so that's something that we take very, very seriously in these kind of situations. So we need to pay attention to that. And you have then the pure depressive phases with or without psychotic symptoms. These patterns of waves of manic phase, depressive phase can happen at various rhythms and various frequency. There are people who have more than 4 of these episodes per year. When this is happening, we call this rapid cycling. And the importance of making these diagnostic distinctions in the phenotype, in the presentation of the illness, is that this makes a difference in the treatment. For example, someone who has rapid cycling like that will try very hard to avoid antidepressants because that could be adding oil on the fire and that could increase the cycling and increase the rapidity of the episodes. So all these little things are important. Then comes comorbidity. Bipolar disorder, one of the reasons for which it's difficult to diagnose sometimes, it's because it's a great chameleon. It hides underneath all sorts of other things. Substance abuse, gambling, addictions to all sorts of things, behaviors that are out of the character of the person, but sporadic. So there's a lot of comorbidities. I just named a few. Lots of anxiety disorders, and we'll get into that a little bit later. Also eating disorders sometimes, and all sorts of other diagnoses that can mask the underlying problem, which could be an unregulated mood that could be called a bipolar disorder. Now, how do we recognize? Let's get into the symptoms now. Hypomania, mania, what do we mean by that? So these are all the same symptoms, but various intensity. Okay, so the most valid symptom of hypomania, mania is decreased need for sleep. So that every term is important there. Need for sleep, especially. So the person is not sleeping as much. If they tell me, well, I'm very tired because I don't sleep well, I don't worry too much of hypomania there. If the person tells me, well, I'm sleeping 3 hours a night and I'm full of energy, full of ideas, want to do all sorts of things, well, a red light turns on in my mind, okay? And should turn on in all over the mind. Increased energy and or motor agitation. So the person has more energy, more thoughts, racing thoughts, and the thoughts are racing. So important here to distinguish with ruminations. Someone who is very anxious, as it happens a lot in bipolar disorder, they can be very anxious and ruminate about the problems, the issues to do, the potential problems, even if they don't exist. When someone is anxious, they tend to, unquote, invent problems. It's a bit pejorative, but what I mean by that is that they tend to see problems where there are no problems, okay? They tend to exaggerate maybe the importance of the challenges ahead, and they ruminate about that. It's always the same thoughts that come back, always the same ones, okay? And they cannot sleep because they think about all these problems, potential problems. These are not racing thoughts. These are ruminations. This is not hypomania. This is someone who is being anxious. Not the same treatment at all. So irritability. Everybody who describes or read about mania or hypomania, they say, well, they are overly happy. They're the fun of the party. It's very fun. They're euphoric about everything. In fact, the most frequent symptom is not that, except maybe at the very beginning of the episode. Most of the time, it's irritability. How come you don't think that my business plan is not good? You don't nothing. You're stupid. You don't want to listen to me. I'll do it myself. I've seen so many stories of patients going to their boss and saying, listen, you don't know how to run your company. I'm quitting your company. I'm going to create my own, and in 1 year from now, I'll come back and buy your company. Goodbye. So I've seen these stories so many times, so it's a common issue. So classic euphoria, elation, yes, especially in hypomania. Hypomania is something that tends to go underneath the radar screen. Everybody is happy. The patient is very happy, lots of energy, lots of IDs, sometimes good. Bipolar patients are very, very creative. There are books written about that, and there are research being done, and there is research being done on this. So many artists, many politicians, many good businessmen had their best ID when they had a little bit of hypomania. Ted Turner, CNN, he created an empire, you know. Lots of determination. The problem is that good IDs need perseverance, and that's the difficulty with this disorder. When they become depressed, everything crashes and everything goes down the drain. Okay, so that's the issue. So euphoria, elation, that's great. It's fun. Doesn't last long. They tend to become irritable. Hypomania, the level of this euphoria, happiness, and so on, and creativity is at a level that where everybody, well, says, well, he's just fine. He's a good guy. He's fun. Invite him to our party. He seems to be the fun of the party. Everybody will laugh and everybody will have a good time with him around. So it goes under the radar screen. The boss in this situation might say, well, my God, you're very productive. You're at the office at 6 o'clock in the morning. Your IDs are great. You're very productive. Happy. The person is not irritable necessarily. And libido is increased, so everybody is happy. So these kind of episodes may go up, may happen at various times of the year, and especially in the spring. We're right in the midst of it now. And everybody is happy, and then they say, well, he gets depressed. And everybody thinks that the hypomania is in fact their baseline. And the patients say, well, I want to be like that. And me, I'm saying, well, I'll give you a lithium, Epival, or whatever treatment we prescribe. And then, as I say cynically to my patients, we're very good in my clinic to crush the party and basically make you more stable, but appreciate stability. You should see the reaction of some of my patients when I say that to them. I don't want stability. I want to be as I was before, meaning in hypomania. So it takes sometimes up to 2, 3, 4 years to get someone to understand and accept that. Okay, so that's a big challenge. Now, in mania, the symptoms are the same, but it's more severe. Everything is exaggerated. The euphoria, the racing thoughts, the creativity turns into grandiose ideas. You know, the self-confidence becomes overly confidence, overconfidence, and the person then says, well, that's when they go see their boss and say, well, you know, I'm quitting your company and starting my own. And that's considered mania, because then the person becomes not a danger to herself per se, meaning that they don't necessarily want to kill themselves or things like that, but they put their financial future, the safety of their family and so on at risk, and this is becoming non-functional by definition. Try to explain that to a judge. That's sometimes a bit difficult, and that's opening another chapter about the legal aspects of when do we intervene, how do we intervene, how to convince a judge that this is dangerous and that this will evolve towards something dangerous, because the law is saying, well, is he a danger to himself right now or to others right now? And what do we mean by danger to someone? That's, anyway, so that could be another hour of discussion, but that's one of the dilemmas that we have in medicine. So what are I thought that maybe we could approach this tonight by using myth and misconceptions about this, bipolar illness. So manic depressive disease and bipolar disorders are two different illnesses. Well, that's false. Manic depressive disorder or illness was a term coined by Kriplin in the early 1900s, 1908 or even 1890 something. And the word manic had a derogatory association in the mind of most patients. In French, when I go talk to Revivre, I had situations like tonight where patients would say, Dr. Beaulieu, I'm not a maniac, meaning a sexual maniac or something of that sort. That's in French the connotation that this word tends to have. So the word manic depressive was changed for bipolar because partly of that, but there are other scientific reasons, and I won't get into all this, but it was to describe the polarity of the presentation of the symptoms in the presentation of bipolar disorder and manic depressive illness. So I won't get into all the academic aspects of this. I want to just precise to you that manic depressive illness is an old term that we don't use anymore much. Now, just trying to quit some animations there. You can see, as I said before, that this illness tends to begin in adolescence, post-puberty, okay? So the problem is that the initiation of the disease is sometimes masqueraded by other, an array of symptoms, such as anxiety, eating disorders, irritability, and so on. Well, again, it's hard to find teenagers who won't have this set of symptoms sometimes. You know, they are adjusting to life and they have anxiety sometimes, and they may have irritability quite a lot. It can happen. And they may have all sorts of situations in which they use substances and so on that may change their behavior and give the appearance of something which is not necessarily a disorder as well. So when we have these situations, our job is to be like Sherlock Holmes, trying to understand what's going on and dissociate everything and try to understand what are the components. But typically, symptoms initially will be more of the depressive, anxious, irritable type of behavior, and therefore, we won't see hypomania and so on. And then when we see hypomania, or what we think could be hypomania, then we scratch our head and we say, well, it seems to me that I've seen my kids doing this too sometimes. They go to bed at 4 o'clock in the morning, they go to work at 9 o'clock in the morning, and they all, you know, tired though, but and so on. And kids do that at this age. So, you know, what do we do? The best judge for that, and I'll give you a clinical example of a young guy, 19 or 20 years old, if it happened 15 years ago. I was assessing him and so on, and he started to tell me a story, and he told me basically he spent a full weekend from Friday evening, well, basically Friday morning, up to Monday morning without an ounce of sleep, nothing. And I said, what did you do? Well, we partied, we did this, we did that, and so on. And my friends were with me, and they were doing the same thing. Oh, yeah? Except, well, I questioned a bit more, and then they said, well, you're right, Dr. Beaulieu. In fact, my friends on Sunday morning, they were crashing on the sofa, and they were saying, well, we're going to bed. And he wanted to go somewhere else and have another party or whatever, they said, no, we cannot follow you anymore. It's out of control. We need to go to bed. And he was full of energy, ready to go. And I thought I was assessing him the following day, and I think he had slept maybe 3 hours in that night, from Monday to Tuesday. So I said, well, this is clear-cut, peer-approved behavior that is outside of the normal range for a group, an age group that is similar, okay? With my white hair, any teenager will look at me and say, hey, you grandpa, who cannot trust your judgment to assess whether I'm overdoing it or not, okay? So, but if I use his friends as a referee, as someone who will judge and comment, then everything is kosher, everything is fine. They will accept, and they will start questioning their own behavior. So you understand the difficulty that we have with these kind of diagnoses until we get signs of hypomania, mania that are clear. And sometimes, unfortunately, even young persons may have a psychotic mania. Then that becomes more clear that this is something of a bipolar nature. But careful, not yet. Because what happens most of the time, we find drugs. We take a urine sample and we find marijuana, we find this, we find that. We find PCP, angel dust, ketamine, speeds, ecstasy, all sorts of things. So most of young persons will experiment with these things, and that can trigger an episode that will look like mania. So we need to sometimes look into this and say, okay, well, how long will this episode last? If it lasts for 3-4 weeks in the hospital after stopping the drugs, then we say, okay, well, it looks like an effect of the drug that is really way too much, way too long to be explained by a drug effect. It is probably a bipolar episode, manic episode that was triggered by the drug and persisted for a long time. So all that requires observation, et cetera, et cetera. And of course, when that happens, the patient will usually say, no, it was the drugs, Dr. Beaulieu, they stopped their pills, and then there will be another episode, and then finally after 2, 3, 4 episodes, sometimes the person will finally say, listen, I think you're right, I have a disorder, okay? So it takes time to accept. So the greatest peak of incidence in terms of age is between that age of 10, let's say 13 to 25, okay? So that's where we see most of the emergence of a diagnosis of bipolar disorder. There is a second peak, which is a bit wider. The second one here, my pad mouse, okay. That one, which is much wider. You can see that this is a large group of patients who have a diagnosis of bipolar disorder that is diagnosed, let's say, in the early 30s. Okay. That being said, remember what I said earlier, 10-year gap between emergence of the first symptoms and the first diagnosis. So it's not clear. And finally, there's a small little peak at the end around the 45, 50 years old group, which can happen there. It's rare that we see that. When we see that, we wonder, okay, is it really the first time that you have had an episode? And when we dig and we do our Sherlock Holmes work, we can identify sometimes episodes that happened in the past that were, again, under the radar screen, hypomanias and manias, very often a lot of depressions. And sometimes, of course, in that age group, not only that age group, but the others as well, we check for organicity. Is there a brain tumor? Is there something else going on that could explain that the emergence of that behavior? And things like strokes, brain tumors, epilepsy, things like that have to be looked into. It's not, they can provoke symptoms of that nature. We can diagnose bipolar disorder with a simple blood test. Is that true? No, unfortunately not. Don't worry, we dream of having blood tests. We dream of having a test in psychiatry that would tell us, hey, this is like an EKG. Cardiologists have it easy, you know. They take an EKG, oh, you have a heart attack, oh, you have this, oh, you have that. In fact, it's not that easy, okay? They have their doubts too. Medicine tends to be fuzzy sometimes, okay? Otherwise, you would not need us. A computer would do the job. That would be easy. So it's the same thing for us. We don't have simple blood tests. We don't have a brain scan that would show that. Of course, there's a lot of research being done about that. And I won't bother you with all that, but there are hopes around the corner, but the corner might be a long time before we get to an application. So, bipolar disorders get worse with time. Is that true? Don't read. I should have put an animation there. No, in fact, this is possible. You know, right now, in the field of bipolar disorder, we tend to rethink the way we would categorize a disorder and become like oncologists. Okay, you have an ovarian cancer stage 1C. What do they mean by that? Well, they mean that the tumor has progressed to this level, there's lymph nodes involved or not, and things like that. So in bipolar disorder, we're starting to think like this. How many episodes did you have in the past? Where are we at in the evolution of the disorder? Most patients will have more than one episode. Most patients will ask me, okay, I had one episode. What is my chance of having another one? Can I stop the pills and simply wait for another episode to happen? And I promise you, Dr. Beaulieu, I'll take the pills as soon as I see symptoms appearing. Well, the likelihood that you will detect the symptoms if you're not an experienced patient, meaning that you had many of these episodes, is likely very small. And that you will be able to stop the episode is also very small. The way I describe it is that you're asking me as your physician to tell you, well, go on the train track. If you see a train coming toward you, make big waves and it will stop probably. Well, try to do that. That won't happen, okay? I want you to be in the engine. I want you to have your hands on the brake and the gas, and you control this machine, okay? You control this disorder. So that's what we suggest. And that involves having a treatment, that involves having also good knowledge of your disorder. You need to become your own patient, your own doctor, sorry. So, therefore, if you ask me, do you see patients who have been stable for 25 years, 30 years on lithium alone? I would tell you no, I don't see patients like that, but they do exist, okay? It's simply that if I would spend my time helping or treating these patients, I would do nothing. They're stable, they're fine, they don't need me, okay? Their GP can take care of that, okay? As long as they monitor the lithium and the treatment properly. So, but this is something that needs to be monitored. Now, I was talking about Kriplin in the 1890s, early 1900. His book is still available. I bought it recently. And this is a graph coming from his publications. In that book in 1921, in those days, they had absolutely no treatments, no electroshock therapy even, no pills, nothing. And he described very well the evolution of the bipolar disorder that he called in those days manic depressive illness. And you can see in blue here the evolution of the frequency of these episodes. And basically, melancholia and mixed states are taking the whole, basically the majority of the episodes as during lifetime. Manias in yellow, as you can see, as the person gets older, it's becoming less and less frequent. So if there isn't a fun in a manic phase, well, it's not really truly fun. A manic phase is not fun at all. But, and on top of it, it's likely over the years to become less and less frequent. And most of the difficulties that we have with the treatment, the reasons for which a patient comes to see us, is to treat the depressive and the mixed states. Bipolar disorder is not a disease. You know, back in 92 or 91, I was in a meeting in the States as a young resident, and the DSM-4 was coming out. Okay, DSM is the classification of all the mental illnesses. And in the States, you know, it's insurance companies that pay for most of the treatments for patients who have treatment. And there was a long debate as to whether we should coin the term or add the term disease versus illness to the disorders that we treat in psychiatry. And as soon as someone suggested to use the word disease, then the other psychiatrists stood up and said, no, don't do that, because if you put disease, the insurance companies will use that against the patients, and they will cut their insurance premiums and insurances. I said, wow, that's different than what we see in Canada, really. So they preferred to use the term disorder or illness as a way to make the term more fuzzy, and so to avoid medical legal issues for the patients, and that could impact on their insurability. We're in Canada. I pretend to be a researcher, at least. And in fact, you know, bipolar disorder is a disease. These are diseases. Depression is a disease for most people. Yes, someone can become depressed due to a divorce or a thing like that, and maybe they'll be lucky and will not have another episode. But the people we see in our programs, in our clinics, are people who have recurrent depressions, recurrent episodes of major depression, recurrent episodes of bipolar mania or bipolar depression. So these are disorders or disease, use the term you want, but these are something that are neurobiological in nature. They can touch a large portion of the population depending on the definition you use. They affect men as well as women. As I said, it's very democratic. There's no, I treat people who are very rich. I treat people who are very poor. It goes across the board. No distinction that stands. Now, this nice little colorful diagram, which I carry with me for the last 30 years, because that's been basically the focus of my work, is from Nick Barden in Laval University, with whom I did my PhD back when I was a young guy without too many white hair. And it explains the fact that of all the history of psychiatry, one of the stories that is the most consistent and persistent and valid is the fact that in depression and in bipolar disorder especially, there tends to be a high secretion of stress hormones. We see a hyperreactivity to stressors, and that is regulated by this complex circuitry that's there, which I won't focus on too much. But just to let you know that we do understand that circuitry, we do understand a lot of the function of various parts of the brain that modulate that response to stress, and I will exemplify that a little bit. These are studies that have been done in transgenic mice, basically mice that have been genetically engineered to be hyper-responsive to stressors, like our patients who are depressed and our bipolar patients. And basically, they lack a certain receptor in the brain. They have a decreased expression of a certain receptor that we call glucocorticoid receptor, which binds the cortisol in circulating, or corticosterone in humans, and basically triggers or controls the stress response. So these animals which lack or have a decreased receptor expression in their brain, they have this increased reactivity to noise. Okay, I will simply keep it at that. If we treat them with antidepressants, then that receptor in the brain that controls the stress response is increased, goes back to normal levels, and then the response to these loud sounds is decreased, and in fact, back to what we would see in normal mice who don't have any genetic abnormality. We can do that to our patients as well, okay? We don't torture our patients. It's part of the research. If you come to my group, you'll see that we will offer you to participate in some of our studies. And this is an example of a setup for startle, acoustic startle. So we expose patients to loud noises. I won't do that now because if I clap my hands, the guys in the back will jump to the ceiling, but the loud noise. But if I do that, and especially if we are in a dark, dark room and we're watching a horror movie like Aliens 3 or something of that sort, you're likely to jump a little bit, okay? And what will happen? You'll blink your eyes also. You won't necessarily realize that you're doing this, but this is happening. You have no choice. This is programmed in our brain. We all do it. So in the context of a stressful situation, that will increase the response, okay? But just exposing you to a loud noise, even without putting you in a context of fear, you will blink your eyes. And we're not sitting there in front of you and watching your eyes blink. Don't worry. That's scientifically done. So we put electrodes like this lady has around her eyes, and the computer records the contraction of the muscles. And it's all, very precise. And we do averages, we repeat, and so on and so on. So look on the right. Focus on the right. You'll see that in red, these are subjects who have been selected without any history of psychiatric disorders, and on top of it, without any family history of psychiatric disorder. Now, I always joke by saying, well, it took us a lot more time to find these subjects than to find our patients, because try to find a family who doesn't have an history of psychiatric disorders somewhere, somehow. It's very tough. But we managed, and we found maybe 24, 25, and we had 24, 25 patients, bipolar 1 and 2, mostly 1, who were euthymic. What we mean by that, they were fine. They were not depressed. They were not clinically depressed, and we measured the intensity of their depressive symptoms or manic symptoms the very same day that they were tested. So they were at their best possible shape, treated also. And look at that. They react a lot more to these acoustic stimuli, loud sounds, than the other subjects, control subjects, do. Very similar to what we see with our transgenic mice. So where am I going with this? I'm going with this to the point to say that, in fact, these patients, bipolar disorder, patients who have a bipolar disorder, what I will say to you, explain to you in the next few minutes, is that they are programmed to react, to hyper-react to stressors, to events. And any clinician who treats a lot of bipolar patients will know that, okay? I've seen patients having maybe a flat tire on the 20, coming to the Douglas and so on, and they come to my clinic in a panic, as if I was, as if they could, I was wondering, will I have to hospitalize them? And they were in a panic. So the issue is that they are hyperreactive to things, and you see that the stress and the stress hormones, the glucocorticoids, you see the blue arrows going down. This is decreasing, for example, a factor of growth, a growth factor in the brain that we call BDNF. The name is not important, but it decreases growth factors for neurons in the brain. Decreases neurite sprouting. The connections between the neurons are basically shrinking down a little bit because of these stress and because of these stress hormones. The generation of new cells, new neurons, because yes, despite white hair and so on, we always form new neurons. Hopefully tonight, after the end of this talk, you will have had a few more neurons that will be stimulated and will sprout. And, we can measure these things. And what you see with the lithium, the valproic acid, antidepressants, and so on, it's the reverse effect. So I'm showing this slide. It sounds very complex and complicated, but I believe it's important to show that because one of the questions my patients are always asking me at some point, usually at the beginning of their treatment, is that, Dr. Beaulieu, when will I get off these pills? They are killing my brain. They are killing my neurons. They are shrinking my head, and et cetera, et cetera. They have all these fears, justified, that these pills will, affect their functioning and cognitive functioning and so on. Yes, of course, if we overdo it and we give you too much, yes, it can do that. It's all a question of measure. But the issue is that, in fact, these molecules, these compounds, will protect the neurons, will protect the brain, and will protect your cognitive functions. So that's an important message. If you remember that, tonight, that already is a very good message to understand. So this is a brain imaging study done by one of my graduate students, Fernando Corbelan, and Hypomania was really the expert in our Center for Brain Imaging, addressing the control of emotions. And the little yellow dot that you see there is basically what's the result of the subtraction of the activity of a bipolar brain minus what we see in control subjects. So you see only what's the difference, basically. And the difference is that you have this hyperactive amygdaloid structure, which is the source of the control of the stress response. And what we do, we put them in the MRI, and we show them disgusting images. Some neutral faces, some disgusting scenarios where there is blood all over the place, a knife stabbed in the chest, or things like that, and awful pictures, amongst other pictures that are neutral and so on. I won't get into all the technique, but basically, these patients and subjects have been trained before to imagine a scenario in these when they see these kind of images that will counteract their negative impact on their brain. Well, this person is, my God, in ICU, I see tubes all over the place, IV lines and so on and so on. This is awful. He might be dying. No, in fact, he's in the hospital. He's in ICU. The doctors have everything under control, and he is fine. Look at the EKG behind. You can see that the rhythm is perfect. He will survive all this. Control subjects, and that's what you see here, they can reverse their initial hyperreactivity, which takes maybe a few seconds to happen, and then after 5, 6, and then 10 seconds, this hyperreactivity is all gone. The amygdala goes back to normal. They're able to do it. Look at the bipolar patients, it stays up. They cannot undo this hyperreactivity. So think about my patient who had a blowout on a Highway 20. Well, Dr. Beaulieu is always late anyway, so it doesn't matter. So I'll be fine, I cannot kill myself because I had a flat tire. Dr. Beaulieu will understand. Let's not panic with that, He could have said that to himself. That would have been fine. So this is the kind of issues that are difficult to address in clinical work, because we are facing, and that's a diagram that simply explains that the part of the brain in the frontal cortex that controls this amygdala in the limbic system is not connecting properly with the limbic system. So your capacity to understand, to relativize, to prioritize things, to analyze things is basically decreased in these kind of in patients with bipolar disorder. That's what we think is happening. In major depression, this is a transitory phenomenon. This is a transitory problem. It gets back to normal, we think, with treatment. In bipolar disorder, there is still a deficit that's left. So there's a lot of difficulties to control, to modulate that neural circuitry that controls the stress response in bipolar patients. And that's why it has been studied even in brothers or sisters of patients who have bipolar disorder and who don't have bipolar disorder themselves. And what do you see again? Even non-affected relatives of bipolar patients also have a tendency to have this increased hyperactivity or reactivity in the amygdala. So what am I saying to you? I'm saying to you that bipolar disorder it's something biological. It's not your fault. The neural circuitry is built this way. Bipolar patients are built to be hyperreactive, to be reactive to stimuli. Okay, so their mood has more difficulty to be modulated by the frontal cortex and so on. So, and that's what we want to train our patients to do. So how can we counteract that? So the brain is great because if it doesn't work by going by this door, let's use another door. Let's use another circuit maybe to reach our goal. I compare this to the SWAT team, okay? You make sure that all the entrances are blocked and that you will enter that house by all the entrances, okay? And that's what we do. That's why we use medication plus psychotherapy plus this plus that. Now, what kind of psychotherapy is the best? Is cognitive behavioral psychotherapy the best for everything? I have my doubts about that. It can work, but is there other ways to help our patients as well? So one day, my senior psychologist years ago, Nancy Poirier, came to me and she said, Serge, we should do meditation. I looked at her and I said, you're not serious. Meditation. What is this thought that you have there? Where did you go last weekend? Any training somewhere in the States that you had and now you want to implement that in our program? And I said to her, listen, if you want to do that, prove to me that this could be useful for bipolar patients, because at that time we had absolutely no data in the literature about that, no data. So that would be a venture, that would be research, okay? And I said to her, okay, create a PowerPoint presentation on this, present that to the team, convince me that this could be useful. So she presented me data showing that in bipolar depression, this little structure there called the insula, and I won't give you a neuroanatomy course, I will simply tell you that 30 years ago, when I was even a younger kid than before, no white hair, I think, in those days, my master degree supervisor in neuroanatomy told me, Beaulieu, you want to become a neurochemist? Well, you'd better learn the neuroanatomy of the brain first, because biochemists are very bad with neuroanatomy and they tend to grind everything in a mush and analyze everything and pretend that they can apply that to the brain. That's not true. And I was studying, you know what, the amygdala, because that's the area that has been my focus of attention for the last 30 years or so. And then I asked a question about the insula. And he said, don't bother with that. It does nothing. We don't know what it does, really. It's not important. Focus on the amygdala. Well, now I'm glad to say that 30 years later, even neuroanatomy has evolved. You know, we keep discovering things. So insula is one of the new things that has been developed. So I'll go right away to the crux of the presentation here. Let's focus on the bottom part. People who have had training in mindfulness-based cognitive therapy. That's what my senior psychologist wanted to study, and she did. She's now writing her PhD on that. And basically, this is the work of Zindel Siegel in Toronto. Zindel is a Montrealer. In fact, he studied at Concordia, worked a little bit at the Jewish. He's a good friend, a good guy. And basically, we called Zindel and we said, Zindel, do you think we could do mindfulness-based cognitive therapy on bipolar disorder? And he said, well, it's never been done, but it's very interesting and I'm happy to help. So we did. We did run some studies, and I will show you some, I will talk to you about some of the results. But this is the work basically of this group, and you can see here in the brain, and you can see that I'm showing you a lot of pictures of brain and things like that. It's because I want to give you the message that psychiatry is not all fuzzy. It's also neurobiological. It's also neurological, okay? But I don't want to make things more complex than they are. But basically, you see here people who have never had any training in mindfulness, okay? Compared to people in red who had training in mindfulness. And basically what happens is that when you present to them these awful images, their metabolism in the insula goes back to normal instead of being decreased as what we see in depression. So basically, the insula is another area that may play a role in the integration of the information about the effect, the mood, and the stimuli from the outside world. And this area goes hypometabolic when the patients are depressed. With mindfulness, we can reverse that. The question is, will it have a big, powerful effect on depression? That remains to be established. 2 weeks ago, I was in Paris at the International Day on Bipolar Disorder. As you may know, this is now an official day on March 30th. This is the anniversary of Van Gogh, who had bipolar disorder. So March 30 has been officialized as being the International Day on Bipolar Disorder. So the Association of Patients in France created an event around that. And this is why the slide is in French here. But basically, it summarizes all the publications so far that have been presented in mindfulness, on mindfulness-based cognitive therapy in bipolar disorder. So as you can see, the list is getting longer. I can tell you that 2-3 years ago, it was maybe 4 lines. Now it's maybe close to the double. So there is an effect, a small effect, mind you, on depression. Patients who have mindfulness is mostly to maintain the antidepressant response, to prevent a relapse into depression. So the effect, though, on patients who have mild residual symptoms of depression is still significant enough to see something happening. Their mood is getting better. The anxiety, that's an important point that relates to what I was talking to you about, the amygdala being hyperreactive and so on. With the mindfulness, the anxiety goes down a little bit. And the sleep, the quality of the sleep is improved. So we're preparing publications on that. So there is hope that we can, by using different neurological circuits in the brain, that we could overcome this, this deficit between the connection of the prefrontal cortex and the amygdala that generates these kind of hyperreactivity to stressors. Now, another question that comes from all my patients is that, Dr. Beaulieu, again, I don't want to take pills all the time. I prefer to, if I have symptoms, I prefer to be quite active and proactive and stopping these symptoms from happening and preventing another episode from happening. Well, as I said, I've seen many patients trying to do that, and I don't reject patients who stop their pills. I say to them, well, listen, if you want to absolutely to stop the treatment, I cannot force you to take the treatment, but at least let me follow you. And let's decrease the pills very slowly so that we have time to react and maybe correct the problem if there is a problem. However, very often there is another relapse, and the impact is the following. One of the impacts. These curves, you can see 3 curves there. These are all in the bottom, all the neuropsychological measurements that neuropsychologists do on cognition, memory, concentration, all that stuff. You can see that when the person has had 1 episode of mania compared to controls, well, they're still in the normal range, which is on below that dotted line there. 2 episodes, well, some of the neuropsychological variables become very close to become abnormal compared to controls. 3 episodes of mania, and that's it. Then you start having deficits in terms of cognition. Okay? Worse when this is with psychotic mania. Okay? So the issue is that the message here is that this series of bipolar disorders, these are recurrent disorders. It's not because there is 1 episode that there will be only 1 episode. They can happen over and over and over again. We need to control that. So that's an important message, because the impact on the cognition, concentration, memory, function, and so on will be unfortunately negative. Okay? There will be an impact. And then people will argue with the doctor, well, that's the pills, doctor. Well, I showed you data before showing you that the pills, in fact, protect the neurons, increase the number of neurons, increase the number of connections between the neurons. And in fact, they protect the brain. So that's the opposite that happens. So Look at the impact on the response to treatment now with the number of episodes. At the bottom here, the number of episodes. The magic number is 10, according to that study. It doesn't necessarily mean that this is 10, but it's around that. You can see here response to lithium, okay? Good response for many years, and then when you reach the number 10 episode, then lithium, even lithium, does not work much anymore. You start losing effect. And that's another question that patients ask me. How come my treatment doesn't work anymore? How come? That could be one of the answers if that person had many episodes. Look at the epival. The response is increasing as the number of episodes increases. Okay, so again, these are crucial pieces of information for clinicians, for us, and for patients as well, because it means that if I have someone, a new patient who comes in with a history of 20 episodes of mania and depression and so on, the likelihood that I will use lithium will be probably less than going for epival. If the person is abusing substances, has a problem of cocaine addiction, for example, I will go straight to the epival, straight, okay, for other reasons that I will show you later. So all these pieces of information and research help us to guide the treatment that we choose, okay? That's an important point. Look at the improvement, though, because there is hope, though. I'm telling you that, yes, cognition will go down. My God, I'll get out of here tonight and I will be depressed. If I continue like this, I will make all of you depressed. That's not my goal. So there is hope that, in fact, there is improvement of and recuperation of the concentration and cognitive function over time. It may take a year, though. Okay, that takes time. And that's difficult for patients to accept and tolerate, okay? But it takes time, but it's visible. So the next point I want to make is that look at what happens, though, between patients who abuse substance, the dotted line, and versus those who do not abuse drugs, cocaine, or etc. Those who have a problem of drug abuse, on top of their bipolar disorder, the recuperation, the recovery of the cognitive functioning is less than what we see with patients who do not use or abuse street drugs. So again, that's an important message clinically for all of us. It means if you have a patient who abuses alcohol or drugs and so on, gone are the days where psychiatrists would say, well, go treat that first and come back to see me after. If you have a psychiatrist who tells you that, fire the psychiatrist. Go see someone else. The issue is that nowadays, and you can look at CAMH, you can look at the website of NIMH, the modern NIDDA, the modern way to address these problems is to treat the disorders in parallel, together at the same time. Okay? Because you will get nowhere if you try to treat one and not control the other one. Try to control the craving that a guy will have for, let's say, cocaine or another drug when they are in a manic state or a depressed state. So you need to treat the depression, you need to treat the mania, you need to treat the bipolar disorder at the same time, and then control at the same time the substance use. And then the treatment for substance use disorder, well, there are many. They're all difficult. It's not easy to stop abusing. Now, is there any new issues in terms of research? Yes, there is a link between potentially inflammation. This is a big, complex slide, basically telling you that, let me step back. We deal with genetic disorders, okay? Bipolar disorder is probably genetic. I won't bore you with all the studies that have been done on the genetics of bipolar disorder. Like, we could spend a day talking about that. Various sequence anomalies in various genes and so on. All the studies tend to contradict each other. Now, basically, what scientists are doing is accumulating the data, putting this in a mega computer, and hopefully one day a computer will be bright enough and will have enough data to say, well, the patients who have this association of genetic abnormalities, they are likely to develop bipolar disorder type 1 with a comorbid substance abuse, et cetera, et cetera. However, even if they find these genetic abnormalities, if these are present in neurons in the brain, they're likely to be present elsewhere in the body, other organs. So what we see, in fact, is that in the mood disorders in general, we tend to see a lot of inflammation, and into many other disorders as well. I have a patient who has bipolar disorder, had a stroke at maybe 35, has Crohn's disease, and other issues. Okay? Now, very difficult to control is bipolar disorder, and we finally succeeded when basically the immunologist was doing his work on his side to control the Crohn's disease, and me on my side to control the stress level to prevent the inflammation. And because when the patient is too stressed, the Crohn's disease gets a flare-up. It's a well-known issue. So both of us, we were trying to do the best we could, and we got success on both ends when basically we controlled both the Crohn's disease at the same time as the bipolar disorder. Okay, so since then, this patient is doing very well and has been stable for the last 2 years and is back with an active life and so on. So we have to control both. And the inflammation processes, basically the core message here is that inflammatory products, cytokines, to use a scientific term, can basically affect the brain as well, generate an excess glutamate secretion or synthesis, and that can affect basically the neuroplasticity of the brain and affect the mood and affect basically the disease process. Now, I think you all know the name of Michael Meany. You know that? No? So Michael is probably close to a Nobel Prize, and he is a little guy from Pointe Claire. He's at the Douglas, and also the Jewish now. Michael has been at the center of a huge mega project looking at how the environment and how factors in the environment can influence the development of disease. And basically, Michael was joking in the 80s by saying, when I was a grad student at Concordia, I was so stupid in the class. I was the most stupid guy in the class because everybody was focusing on genetics, the genotype. Others were focusing on the environment, those who became psychologists, psychiatrists, and so on. It's all due to the environment. It's all due to the environment. It's due to your childhood, et cetera, et cetera. And others were the molecular guys. They were the top-notch, stars who were focusing on genes and so on. And me, I was still struggling to understand the X in between the two words to see what do they mean by that X? What is this process of interactions between the gene and the environment and how you end up developing a phenotype, a presentation of illness? Those who may have seen my office, I have lots of little jokes in forms of plaques in my office. And one of them is, let me remember it, never mind the dog, beware of the owner. Okay, so basically, yes, good advice. So because basically the behavior of the dog will be a dog behavior. But if the master of the dog does not train the dog or behaves himself very badly toward the dog, well, the likelihood is that the dog will behave very badly with you too. Okay, so bipolar illness is bipolar illness. But bipolar illness is very different depending on what is the person who has the bipolar illness has experienced in their lifetime. Okay, so it's individualized treatment that we talk about. So that's basically the message of epigenetics, the environment affecting the expression of certain genes, the expression of the development of a certain disease, and how this disease will manifest itself. That's what we call the phenotype here on the right side. So now, and I'm almost closing to an end. I think I'm about to run out of time, and I think I'm already out of time. The message of hope here is the fact that if you look at some data, things like the study from Jens Prusner, also at the Douglas. He showed that basically people with low self-esteem, either young or old, they had a decreased volume of the hippocampus. And that part of the brain is very important to control that stress response. So again, an environmental factor, a psychological factor, variable, will have an impact on the neurobiology. So if you address the low self-esteem in group therapy, and we have group therapies for that, you know, they do exist. There are basic, in ACLSCs, they have groups like that for improving the self-esteem. This may have also an impact on your brain, and that may protect the person against having another relapse and having a more severe disorder. So not everything is genes, in other words, okay? So you can also influence the outcome of a disease by influencing the environment. Preventive treatments are not available for bipolar disorder patients. That's totally wrong. You know that, I'm sure. Maintenance medication, lithium, epival, and so on, psychotherapy, psychoeducation. Psychoeducation is extremely important because we all want, at least I always say to my patients, I want you to be able to fire me at some point, okay? So that you can monitor your disease 24/7 better, much better than any doctor can do. And if you know what to look for and when to say, okay, now it's time to go talk to my doctor because I think there's something brewing, there's something happening here. If you want to see treatments and so on, you can go online at canmat.org. And the last update on the guidelines of treatment go back to 2013. Probably in 2017, we'll do another write-up to explain what this is. But CanMat is a Canadian organization. I'm a member of that. I'm on their board. And basically what we do is to do, in addition to doing research and so on, we do a lot of education to the public, to physicians about mood disorders, bipolar disorder, etc. And also we publish guidelines of treatment. What are the best treatments based on evidence-based medicine? So these are the authors in Canada, but also around the world. We have international representation from various continents in the world because we wanted to express the differences between continents. There are trends that are, going in America, but are not necessarily going in Europe or in Asia and so on. So we think that this is, and these guidelines, Canadian guidelines, I must say that they have been adopted by the ISBD as their own guidelines. ISBD is the International Society for Bipolar Disorder. So at least we can be proud as Canadians to have been selected to represent the international body on bipolar disorder. Now, the pyramid of treatment basically stays on basically psychopharmacology. Again, unfortunately, it's basically impossible to treat a bipolar disorder without medication, unfortunately. We would all be happy to be able to avoid that, but so far we can't. That does not mean that there are no or should not be any other additional treatments in addition to that. Of course, there has to be psychotherapy, psychoeducation for helping the person to know their disease and know what to do. Basically, same principle as we do that we apply when we treat diabetes. We teach the person how to manage their diabetes, how to manage their diet, their insulin, and so on. So I've had patients who had to go through occupational rehabilitation therapy because they had to switch to another job. A bipolar 1 patient who works night shifts and has, multiple calls to say, well, could you do a second call, work 16 hours instead of 8 tonight? And by the way, just go to sleep maybe 4 hours and come back because we have more work and we need you. That does not function. These patients will relapse because they need their sleep. Okay, so that's what I say to all my bipolar 1 patients. You avoid the night shift work. It's impossible. Your sleep quality will be poor and you will relapse. So I have had people, for example, working in the cinema industry. Those who create the sets and take care of the lighting and so on. They finish at midnight and they have to be back on the set at 4 o'clock in the morning to prepare the day for the following day and so on. They may as well sleep in their car in the parking lot, and that's not possible. So I won't get into this. The point I want to make about this is that, you know, I highlighted that the bipolar depression is probably the most difficult part of the disease to treat, and it's also the most frequent as the age and the disease evolve over the years. A few years ago, let's say 20 years ago, there was not much treatment available for that. So nowadays, look at this diagram. This is the algorithm of treatment in 2013 for the treatment of bipolar depression. It's enough to make any doctor dizzy. So there's a lot of choices now. But again, you need to follow certain criteria and so on. But I'm just saying to you that there are potential new treatments also coming up all the time. This is a diagram of a study on light therapy that we have completed, a study that we have completed 2 years ago now. We're still working on the data and about to try to publish that. This is light therapy used for bipolar 2 depression, not 1. I don't advise patients who have a bipolar 1 disorder to start light therapy in the fall and expecting that they will be fine, because light therapy is very powerful. Look at the spring now. Last week, I had to hospitalize 3 patients in 1 week, okay, all in mania. Okay, so that's spring. That's the effect of the light, okay? So in this study with bipolar type 2, you remember type 2 are patients who have hypomanias and so on. We had to retire 3 patients out of that study because they were starting to get agitated by the light, okay? So that's more powerful than we think, okay? Now we use big lights, sad light, you know, so they are very bright, white light. There's a lot of research being done on blue lights, red lights, green lights, all sorts of things. And combined with sleep deprivation, green light, and there's a guy in Milan who is sleep depriving his patients, which is a recipe for switching into mania, as you know. And he combines that to, I think, green light at certain time of the night and bright light in the morning. It's a complex paradigm and so on, but it seems to be helpful. So the point I want to make is that there is, you know, even research being done in that domain. And basically what we know, though, of the impact of the light right now in the spring, we all have a rise in serotonin in the brain due to this exposure to more light, okay? And during the fall, it goes down. So what do we do with antidepressants? We increase serotonin. That's all we do with antidepressants, basically. Prozac, Zoloft, Cipralex, Celexa, that's what we do. We want to increase the strength of the serotonergic signal. So that's what we do. The light is doing this. So in the spring, we tend to decrease that stimulation. Sometimes we have to decrease even antidepressants. And I believe this is my last slide. Psychosocial interventions. Again, if you come to our center in our clinic, you'll see that we do a lot of group interventions. Not only because we don't have enough staff to do only individual treatment, but it's because also in groups it's more efficient. There is the effect of the synergy of the group, of the people in the group, but also it's also as effective as CBT. And I didn't put any slides on that, but this is published in 2012. You can look at this is one of the CAN-MAT studies that we've done on psychoeducation. What we did, we compared 6 sessions of psychoeducation in groups versus 21 individual sessions of CBT, cognitive behavioral therapy, modified a little bit to include psychoeducation. So calculate the cost of all that, okay? 21 sessions with one therapist, 1 hour each time, versus for one patient, versus a group of 6 to 8 patients with one therapist, 6 sessions. The results were exactly the same to prevent relapses into mania and depression. So I think we should present that study to the Minister Barrett. That would be a good way to promote psychoeducation. But the results are the same. So basically, that's why we put a lot of emphasis on psychoeducation, because it's giving the patients the power to intervene over their disease and to empower them and to give them a sense of self-confidence in their capacity to detect the symptoms in time, to intervene, to prevent a relapse that will prevent, hopefully, deterioration at the cognitive level and also at the financial, social level as well. So I think that this is really an important issue. So psychosocial interventions are, yes, important, and I think that we can do a lot of mileage with those. So I'll stop here. Thank you for your patience, and I think we'll take a few questions.
I'm just amazed this evening that a man who's obviously so busy takes the time out of his evening to come and share with us and try and teach us and make sure that we're more knowledgeable so that we can help our loved ones. In appreciation, we have this small gift for you.
Thank you. Thank you.
And help. He's such a great teacher. He gets a crystal apple. I hope you'll keep it on your desk.
I will.
Thank you all very much.
Thank you very much. It was a pleasure.